The next topic is the diseases of the dental pulp. What is dental pulp? Dental pulp, it is a delicate connective tissue that is mixed with the tiny blood vessels, lymphatics, nerves, and undifferentiated connective tissue cells. So the dental pulp, it is the part in the center of tooth that is made up of living connective tissue and the cells known as odontoblast. What does the pulp contain? The pulp contains the blood vessels, the nerves, the connective tissue, and provide tooth, blood, and nutrients. What is pulpitis? The inflammation of pulp is known as pulpitis. So what are the causes of the pulp disease? According to the Grossman, they either can be physical, that could be either mechanical, or due to trauma, or due to the pathological wear, crack through the body of the tooth, or barometric changes. The thermal includes heat during cavity preparation, exothermic heat that can be generated during the setting of the cement, conduction of heat and cold through deep restoration without using a protective base, or the frictional heat during the polishing of the restoration. Electrical causes could be either galvanic shock. The chemical cause includes using phosphoric acid or erosion. Third, bacterial cause, that could be associated toxins that are associated with caries, direct invasion of pulp from caries, or anacoresis. According to the Grossman, we can classify the pulp disease based on clinical features into either it can be reversible or irreversible. The reversible can be symptomatic, that is acute, or asymptomatic, that is chronic, whereas the irreversible can be acute, abnormal response to cold, or abnormal response to the heat, or could be chronic, asymptomatic with pulp exposure, hyperplastic pulpitis, internal resorption, pulp degeneration, or necrosis. There may be partial pulpitis or subtotal pulpitis depending upon the extent of involvement of the pulp. If the inflammation is confined to portion of pulp, usually a portion of coronal pulp such as pulp horn, the condition is partial or focal pulpitis. If most of pulp is diseased, then it is total or generalized pulpitis. What is difference between open pulpitis and closed pulpitis? When there is, so this classification is based upon presence or absence of direct communication between the pulp and the oral environment, usually through a large carious lesion. Open pulpitis is used if those cases of pulpitis in which pulp communicates with the oral cavity. When there is no such communication, then it is closed pulpitis. So what is anacoresis? It is transportation of microorganism through blood or lymph to an area of inflammation, such as tooth with the pulpitis. Aerodontologia, the toothache occurring at low atmospheric pressure, experienced either during the flight or during a test run in a decompression chamber. So it is generally observed in high altitude over 5,000 feet. So you have to remember it is seen, aero means air, during a flight or during a test run. A tooth with chronic pulpitis, it will be symptomless at the ground level, but it will at the higher altitude it will cause pain because of the reduced pressure. So treatment, it consists of lining the cavity with varnish or base of zinc phosphate with sub-base of zinc oxide eugenol cement in the case of deep cavities. So let us discuss pulpal disease one by one. The first comes the reversible pulpitis or It is also known as pulp hyperemia. So one of the earliest form of pulpitis is reversible pulpitis. So in this condition, it is a mild to moderate inflammatory condition of the pulp that is caused by stimuli in which the pulp is capable of returning to the uninflamed state following the removal of the stimuli. Suppose we apply ice or cold fluid to the tooth that result in pain, but when you remove this stimulus, it will found that such teeth would return to the uninflamed state following the removal of the stimulus. So the etiology, it could be trauma, thermal shock, excess dehydration of the tooth, galvanism, or bacteria from the caries. So here the tooth will be sensitive to the thermal changes, especially cold. The pain will be of short duration that will disappear on the withdrawal of the thermal irritant. The tooth will respond to stimulus by an electric pulp test at a lower level of the current, indicating a lower pain threshold or a greater sensitivity than that of adjacent or normal teeth. So the teeth that usually show reversible pulpitis are the large metallic restorations, deep carious lesions, or restoration with the defective margins. So what are the histological features? Number one, you will see the microscopically it is characterized by dilation of the blood vessels. Of the pulp vessels, oedema fluids may collect because of damage to the capillary walls, allowing the extravasation of RBC or some diapedesis of the WBCs. There will be slowing of the blood flow, and that could cause thrombosis. So the treatment is the remove the irritant or stimuli before the pulp is severely damaged. If the primary cause is not corrected, extensive pulpitis will lead to the death of the pulp. We can use cavity varnish or base application before the insertion of filling. A care should be taken during cavity preparation and polishing. Next comes the acute pulpitis. What is acute pulpitis? Extensive acute inflammation of pulp is a frequent immediate sequela of the focal reversible pulpitis. Although it may also occur as an acute exacerbation of chronic inflammatory process. So acute pulpitis, it is usually seen in the tooth with a large caries or restoration, commonly a defective one. So severe pain that is elicited by thermal changes, particularly when the patient is taking ice or cold drinks. The pain persists even after the thermal stimuli has disappeared or has been removed. So the etiology, that could be the bacterial invasion, chemical, thermal or mechanical cause, or the reversible pulpitis that may deteriorate into the irreversible pulpitis. So in the early stages, what you will see, it involves a portion of the pulp, usually the area just beneath the carious pulp. The teeth will be extremely sensitive to hot and cold stimuli, and there will be increase in the pain intensity, and that will persist even after the thermal stimulus have been removed. So intrapulpal abscess formation will be seen that will cause severe pain, lancetating or throbbing type. That will be the characteristic feature of the pain. The pain can increase when the patient will lay down. So why does the pain occur? the pulpal pain that is not only caused by the pressure buildup due to the lack of escape of the inflammatory exudate, but also by the pain producing substances that are relieved by the inflammatory. So the pain will subside when the drainage is established or when pulp undergo complete necrosis. The tooth will be not tended to percussion unless the pulpal inflammation has spread beyond the root apex into the periapical region. So there will be a rise in the pulp pressure along with the inflammatory exudate, the local collapse of the venous part of the circulation that will result in local tissue hypoxia, and that will cause the pulpal abscess. Now what are the histological features? There will be continuous vascular dilation that is seen in the reversible pulpitis, accompanied by accumulation of edema fluid in the connective tissue surrounding the tiny blood vessels. So there will be edema in the pulp with the vasodilation, infiltration of the PMN, polymorphoneutrophils along the vascular channels, and that will migrate through the endothelium lined structures. There will be destruction of odontoblast at the pulp dentine border, the abscess that would consist of pulp, leukocytes and bacteria. So what is acute suppurative pulpitis? It is numerous abscess formation that causes pulp liquefaction and necrosis. So the treatment is drainage of the exudate from the pulp chamber. You can do pulpotomy and place calcium hydroxide over the entrance of the root canal or root canal treatment. Next is the chronic pulpitis. So when there is persistent inflammatory reaction in the pulp with little or non-constitutional symptoms. So in the chronic pulpitis, the pain will be not a prominent feature of the chronic pulpitis. There will be dull, mild pain that will be more often than intermittent than continuous. So there will be degeneration of the nerve tissue in the affected pulp, and the threshold for stimulation by the electric pulp vitality test that would increase. So in case of the chronic pulpitis with wide open caries and exposure of pulp to the oral environment, there will be relative little pain. The pulp will become totally necrotic, and so there will be no symptom or little pain. So on histological, there will be infiltration of pulp tissue by varying number of mononuclear cells, chiefly the lymphocytes. So you would see the lymphocytes and the plasma cells. So the treatment is the root canal treatment. Next is the chronic hyperplastic pulpitis. What is that? It is the overgrowth of pulp tissue outside the boundary of the pulp chamber as a protruding mass. So other name of chronic hyperplastic pulpitis is pulp polyp. So it occurs in children, that is the young adults who possess a high degree of tissue resistance and reactivity and readily respond to proliferative lesions. It involves the large open carious lesions. So you will see a pinkish red globule of tissue that is protruding from the pulp chamber that will not only fill the caries defect but also extend beyond. So it is a slow progressive caries. So it occurs due to the slow progressive carious exposure of the pulp, a large open cavity, a young resistant pulp, and a chronic low-grade stimulus, they are necessary for the chronic pulpitis. You will see that the teeth that are more commonly involved by this phenomena, they are the deciduous molar and the first permanent molar, because they have excellent blood supply because of their large root opening and high tissue resistance and activity in the young person. So moving to the diseases of the periapical tissues. So once the infection that has established in the dental pulp, its spread of the process can be only in one direction, that is through the root canals and into the periapical tissue. So what is apical periodontitis? Apical periodontitis is the inflammation of the periodontal ligament. So this periodontal ligament that is present surrounding the tooth, that will get inflamed around the root apex. So this process may be acute or chronic, that will depend upon the virulence of the microorganism involved, the type and severity of the physical or the chemical irritants, and the host response. So what is the etiology of the apical periodontitis? The common cause of apical periodontitis, it includes the spread of infection that can be following the pulp necrosis or occlusal trauma from a high restoration or biting. So when suppose a patient biting on a high restorative filling, so what next can occur? It's the occlusal trauma that can occur from a high restoration or biting suddenly on a hard object. Sometimes over instrumentation or pushing the infected material into the apical portion, or the chemical irritants that can be gained from the root canal medicaments. So the painful inflammation of the periodontium as result of trauma, irritation or infection through the root canal, regardless of whether the pulp is vital or non-vital. So it is also referred as symptomatic apical periodontitis. So the patient suffering from the acute apical periodontitis give the history of previous pulpitis. So due to the collection of the inflammatory oedema in the periodontal ligament, the tooth will feel like it is elevated in the socket. So suppose you get a question, the patient complains that tooth is slightly elevated in the socket and tenderness while biting or even mere to touch. So what is your diagnosis? This question has been asked multiple times in the entrance exam. The answer will be here is the acute apical periodontitis. So what you will see here is the external pressure on the tooth that will force the edema fluid against already sensitized nerve endings, and that results in severe pain. So on the radiograph, so the tooth is tended to percussion and pain can be severe, making closure of teeth difficult. So what are the etiology of the acute apical periodontitis? It can be due to the occlusal trauma, wedging of the foreign body between the teeth, blown teeth, or any orthodontic pressure. Or in case of non-vital teeth, it could be due to the sequel of pulpitis during root canal therapy. There can be forcing of the irrigation or irrigants through the apical foramen, or extension of the obturating material, that is the gatta pacha, through the apical foramen. So what would be the clinical feature? Thermal changes does not induce pain. The patient will feel that the tooth is extruded from the socket. So patient complains of slight extrusion of tooth from the socket. The patient will complain of tenderness on mastication due to inflammatory edema collected in the periodontal ligament. So if the irritant is not removed, it progresses with the resorption of the surrounding bone. And if the inflammation is transient, it is caused by the acute trauma. Acute abscess may occur if it is associated with bacterial infection and is known as acute periapical abscess or alveolar abscess. So what would be your diagnosis? On clinical you will see the tooth will show TOP, that is standard to percussion will be positive. The radiographic features, you will see the widening of the periodontal ligament, and the histological features you will show the periodontal ligament will show sign of inflammation. There will be vascular dilation along with the infiltration of polymorphoneutrophils. If the inflammation is transient, it is caused by acute trauma. If the irritants are not removed, it will progress into the surrounding bones, causing resorption. And the abscess formation may occur if it is associated with the bacterial infection. It is known as acute periapical abscess or acute alveolar abscess. The treatment, if it is due to the occlusal trauma, we can do selective grinding so that the inflammation may subside, or we can do extraction, or endodontic treatment may be done to drain the exudate. Another term is the chronic apical periodontitis, a growth of granulomatous tissue continuous with the periodontal ligament that results from the death of pulp and diffusion of bacterial toxins from the root canal into the surrounding periradical tissue through the apical and the lateral canals. So this chronic apical periodontitis is also known as periapical granuloma. So what is that? It is a low grade infection. Most common sequelae of the pulpitis or acute periapical periodontitis. If the acute process it is left untreated, and it will turn into the chronic one. Remember, the acute inflammatory process will be exudative process, whereas the chronic is the proliferative process. This periapical granuloma is a localized mass of chronic granulation tissue that is formed in response to the infection. So the most important point, that is the tooth here will be non-vital. It is usually non-vital and may be slight tender to percussion. On percussion you will hear a dull sound instead of the metallic one. In some cases, the patient may feel the tooth is elongated in the socket. The patient may complain of mild pain on biting or chewing on the solid food. The sensitivity is due to hyperemia, edema, and there will be inflammation of periodontal ligament. No perforation of bone or oral mucosa forming fistula tract unless the lesion undergoes acute exacerbation. What will be the radiologic features? The earliest periapical change in the periodontal ligament will be there will be thickening of ligament. There will be thickening of periodontal ligament at the root apex. As the resorption of the bone continues, this granuloma will appear as radiolucent area of variable size. So this radiolucency will be well circumscribed and definitely demarcated from the surrounding bone. So sometimes you will see a thin radiopaque line or zone of sclerotic bone that may be seen outlying the lesion. So this indicates a long-standing lesion that may show a varying degree of root resorption. So this one figure will represent a ill-defined radiolucency that is present with the mandibular first molar, and you can see there is a significant root resorption. So on histological, you will see hyperemia and edema of the periodontal ligament. With the infiltration of the chronic inflammatory cells, there will be vascularity of the tissue that is associated with the resorption of surrounding bone, the granulation mass that will consist of proliferating fibroblast endothelial cells and immature blood capillaries. So in some granuloma, what you will see is large number of phagocytes that will ingest lipid material and form cells. Abundant mast cells can be seen deposit of cholesterol and hemocidrone. They are derived from the breakdown of extravasated RBCs. So the epithelium of periapical granuloma, they may also originate from the respiratory epithelium of the maxillary sinus, oral epithelium in through a fistulous tract, or oral epithelium proliferating apically from the periodontal ligament. Also you can see bacteriological features like S. viridans, S. hemolyticus. These bacteria are isolated from the lesions. The treatment is extraction and RCT with or without apicectomy. If untreated, you can see apical periodontal cyst formation. Other comes the periapical abscess, periapical abscess, dentoalveolar abscess, or the alveolar abscess. So it may either develop from the acute periapical periodontitis or from a periapical granuloma. So what is phrenic abscess? Acute exacerbation of the chronic periapical lesion is known as phrenic abscess. It usually arises as a result of infection following carious involvement of the tooth and pulp infection. So that is the most important point that you have to remember for your entrance exam. They ask it multiple times, what is phrenic abscess? So the periapical abscess is acute chronic suppurative process of the dental periapical region. It can develop from either acute periodontitis or apical or periapical granuloma. Etiology could be traumatic injuries, pulp necrosis, or irritation of the periapical tissues. So what are the most common clinical findings? So the acute periapical abscess that presents with the feature of acute inflammation of the apical periodontium. So the tooth will produce tenderness that is often relieved by application of pressure. So on applying pressure, the patient will feel relief. The most common finding of inflammation would be heat, redness, swelling, and the pain. The tooth would be extremely painful and it feel like it is extruding from the socket. Along with that, you can see systemic manifestation like lymphadenitis, fever that may present when it is confined to the periapical region. It may show a rapid extension to the adjacent bone marrow space that can produce acute osteomyelitis or dentoalveolar abscess. So you can see this a palatal abscess that is an extension of the periapical. The palatal abscess, it is an extension of the periapical abscess. On the histological features, there will be area of suppuration composed of PMN leukocytes, lymphocytes. There will be dilation of the blood vessels. The marrow will show inflammatory infiltrates, and the tissue round area shall show suppuration containing serous exudate. On radiograph, what you would see is the slight thickening of the periodontal ligament space and radiolucent area at the apex of the teeth. The treatments, you can drain the abscess by opening the pulp chamber. You can do root canal treatment. If it is untreated, it may cause osteomyelitis, cellulitis, or formation of fistulous tract or any opening to the oral mucosa. So this we have discussed. Acute exacerbation of chronic lesion is known as phrenic abscess. Coming to osteomyelitis, what is osteomyelitis? It is the inflammation of the bone and its marrow content. So in osteomyelitis, what you will see is there will be involvement of the bone, the infection that will spread through the bone to the large extent. It is a common complication of the dental sepsis. So here the inflammatory condition Osteomyelitis is an inflammatory condition of the bone that begins at an infection of the medullary cavity that rapidly involves the Hawaiian system and extends to involve the periosteum of the affected area. So the inflammation of bone and its marrow content is the osteomyelitis, and according to the Neville definition is acute or chronic inflammation process in which the medullary spaces or the cortical spaces of the bone that extend away from the initial site of the involvement. So these are the classification of the osteomyelitis. It could be suppurative osteomyelitis or non-suppurative osteomyelitis. The suppurative osteomyelitis can be acute suppurative, chronic suppurative, primary chronic suppurative osteomyelitis, secondary chronic suppurative osteomyelitis, infantile osteomyelitis. And in non-suppurative osteomyelitis, it can be either chronic sclerosing osteomyelitis, that could be focal or diffuse, Gary sclerosing osteomyelitis, actinomycotic osteomyelitis, or radiation associated osteomyelitis. What are the predisposing factors for the osteomyelitis? The predisposing factors that include fracture due to the trauma and road traffic accident, gunshot wound injuries, radiation damage, Paget's disease, osteoporosis, systemic condition like malnutrition, immune dysfunction, acute leukemia, uncontrolled diabetes, sickle cell anemia, chronic alcoholism, all may predispose to the osteomyelitis. What are the ways by which microorganisms may infect the bone? They can infect the bone through three routes. One, by the hematogenous. Second, direct inoculation of the microorganism into the bone. And third, by the continuous focus of the infection. So the osteomyelitis of jaw is mainly caused by spread of adjacent odontogenic infection that is followed by a traumatic fracture. It is more common in men than in women. So these are the microbiology of the osteomyelitis. What is acute suppurative osteomyelitis? It is a serious sequelae of the periapical infection. So here you will see is the diffuse spread of infection through the medullary spaces. So the clinical features of this form of osteomyelitis that arise from the dental infection are same as that present after the infection due to the fracture of the tooth. So the dental infection, it is the most frequent cause of the acute osteomyelitis of the jaw, or it can spread through the fracture of the jaw, gunshot, or hematogenous spread may occur. So it is a polymicrobial infection, means that there will be different type of organisms that might be cultured from these lesions. What are the most common organisms that are seen? The most common they are Staphylococcus aureus, S. albans, anaerobes may be seen, bacteroides, Prevotella, etc. So the patient will have severe pain, trismus, paresthesia of the lips in case of mandibular involvement, and there will be elevation of the temperature. Patient presents with a fever with regional lymphadenopathy. The WBC count is elevated, the teeth are loose and sore. Pus may be exudating from the gingival margin. On radiograph what you will see is the acute radioosteomyelitis. The acute osteomyelitis progress rapidly and demonstrate little radiographic evidence of its presence. At this time you can see a diffuse lytic changes in the bone that begins to appear. So the treatment part consists of debridement, drainage, and antimicrobial therapy. Now, what is the pathology of osteomyelitis? First of all, you will see acute inflammation of the marrow spaces. So there will be spread of this exudate along the marrow spaces, and thrombosis of the vessel may occur due to the compression of the vessels that will cause necrosis of the bone. So these necrotic tissues, the dead and dying cells will form the pus from the bacteria and will fill the marrow spaces and involves the cortical bone, causing lifting of periosteum, causing further necrosis, and finally you will see is the sequestrum, that is the osteoclastic activity. The clinical features: the mandible is more diffuse and widespread, whereas maxilla is localized. So this is the radiographic features. You can see trabeculae becoming fuzzy and indistinct, ill-defined margins. So on histology, you will see necrotic bone, loss of osteocytes from their lacunae, peripheral resorption. The medullary spaces may be filled with inflammatory exudates. So the inflammatory cells, they are mainly the PMN. So osteoblast borders of the bony trabeculae are destroyed. So treatment, again it is 3D. 3D stands for debridement, drainage and the drugs. So what are the complications? You can see pathological fractures, chronic osteomyelitis. It may progress to the acute cases may progress to the chronic osteomyelitis. There may be cellulitis, septicemia. The chronic osteomyelitis, it can be subdivided into chronic suppurative osteomyelitis, chronic diffuse sclerosing osteomyelitis, or the chronic focal sclerosing osteomyelitis or sclerotic segmental mass. First comes the chronic suppurative osteomyelitis. So it occurs in inadequately treated acute osteomyelitis. So there will be rarely complication of the irradiation. So clinical features, they are same as that of acute osteomyelitis, but the signs and symptoms are milder. The pain is severe. The temperature, it will be still elevated, but only mild temperature may be seen. The teeth, that may be sure, loose. Mastication is possible at least. The suppuration, that will perforate the bone, overlying skin or mucosa to form a fistulous tract. The treatment, we can consider antibiotic therapy. Hyperbaric oxygen may be given. So the surgical intervention may be mandatory. Antibiotics may be given. The small lesions, they may be treated by curettage, removal of necrotic bone and decortication, whereas the extensive osteomyelitis can be treated by decortication combined with transplantation of the cancellous bone chips. Whereas the persistent osteomyelitis, here resection of the diseased bone followed by immediate reconstruction with the autologous graft is required. Next is the chronic focal sclerosing osteomyelitis. Other name is condensing osteitis. So what is condensing osteitis? It is an unusual reaction of the bone to the infection, a reaction to the mild bacterial infection that enter the bone through a carious tooth. It occurs in patients who have high degree of tissue resistance. So remember for your exam, The disease that occurs to a carious tooth in person who have high degree of tissue reaction and tissue activity is it is condensing osteitis. What is the name of other name of condensing osteitis? It is chronic focal sclerosing osteomyelitis. The disease that is occurring as a result from the good patient immunity and a low degree of virulence of the offending bacteria is it is condensing osteitis. So, which tooth are more commonly involved in condensing osteitis? It is the mandibular molars. It involves young adults and children. What are the radiographic features? You will see well circumscribed radiopaque mass of the sclerotic bone surrounding and extending below the apex. So in this figure you can see is the radiopaque mass that is surrounding below the apex of one or both the roots. Along with that you can see the periodontal ligament widening. On histologic appearance you will see dense bone trabeculae with little interstitious marrow tissue, reversal and rafting lines that can give a pegytoid appearance. The treatment is root canal treatment or extraction. Next is the chronic diffuse sclerosing osteomyelitis. So it is characterized by non-suppurative inflammatory process that is associated with recurrent swelling, trismus and pain. It is common in the edentulous mandible. So remember, in contrast with the focal type, the chronic diffuse sclerosing osteomyelitis is more common in the edentulous patients. It is more common in the older patient, in the edentulous mandibular jaws. You may see a spontaneous formation of fistulas that may be opening on the mucosal surface to establish drainage. On radiograph what you see is diffuse patchy sclerosis of the bone. As you can see a coatal wool-like appearance. Sometimes bilateral appearance may be seen. It may involve the both maxilla and mandible of the same patient. Border may be sclerosed. On histologic, you will see irregular tabulae of bone that is bordered by active layer of osteoblast. There will be presence of reparative and reactive new bone formation with abundant osteoid and osteoblastic ring. You may see a mosaic pattern appearance that is indicative of repetitive periods of resorption followed by the repair. So in this peak you can see is irregular trabeculae of bone that are bordered by active layer of osteoblast, proliferating fibroblast and small capillaries as well as small foci. Collection of lymphocytes and plasma cells may be seen. So lesion can be too extensive to be removed surgically. Sclerotic bone is hypovascular and resistance to antibiotic. Extraction of tooth may be considered as last option, utilizing a surgical approach with the removal of the liberal amount of bone to facilitate extraction. Important term is what is Cepheus syndrome. So it is characterized by synovitis, acne, pustulosis, hyperostosis and osteitis. So there are three diagnostic criteria for the Cepheus syndrome. Remember that for your multiple exam point of view, number one is multifocal osteomyelitis with or without skin involvement, chronic joint inflammation that will be associated with pustules or psoriasis on the palm, soles, acne, and sterile osteitis that is present in one of the skin manifestations. Other important term is chronic osteomyelitis with proliferative periostitis. Other name is Gary osteomyelitis. So what you will see a disease that is that is characterized by focal gross thickening of periosteum with peripheral reactive bone formation if it is Gary's osteomyelitis. So what you will see is there will be reactive periosteal thickening due to low grade irritation or dental infection. So remember, Gary's osteomyelitis, it is more common in the young person before the age of 25 years, more common in the mandible of the children and young adults. What you will see is the hard swelling over the jaw producing facial asymmetry. Cellulitis may be there involving periosteum. The overlying skin could be normal or could be inflamed. So this is picture representing in young adult showing the Gary's osteomyelitis. In radiograph, what you will see a carious tooth opposite the hard bony mass. Carious tooth on occlusion radiograph, you will see there will be the overgrowth on the outer surface of the cortex. So it will appear or described as duplication of, like you will feel there will be a duplication of the cortical layer of the bone. So on histology, what you would see is periosteal mass that will composed of much reactive new bone and osteoid tissue with osteoblast borders. These trabeculars will be perpendicular to cortex and parallel to each other. Along with that, you can see lymphocytes as well as the plasma cells. Treatment is the endodontic treatment. No surgical intervention except biopsy to confirm the diagnosis. Last is the sclerotic cemental mass. It is common in the black females. It is large, painless, radiopaque mass involving several quadrants of the teeth. So this condition has been previously described as chronic sclerosing osteomyelitis or gangreniform cementoma. So these lesions may be more appropriate to consider them as benign fibrosous lesion of the periodontal ligament origin. On histological appearance, you will see cemental mass that is interrupted by cementum, unlike diffuse, mostly have the sclerotic bone. The cementum is in form of large solid mass with smooth lobulated margins. Along with that, you may see cellulitis. What is cellulitis? It is the diffuse inflammation of the soft tissue that is not circumscribed or confined to one area, but it tends to spread through the tissue spaces and along the facial spaces. If drainage is not done, then it may spread diffusely into the facial spaces or the soft tissue. So it occurs as results of infection by the microorganisms by producing significant amount of streptokinase, hyaluronidase and fibrinolysin. So these enzymes act to break down or dissolve the hyaluronic acid, the intercellular cement substance and the fibrin. The microorganism involved are Streptococci, Prevotella. So this one is here is the pathology of the cellulitis, and most common organism is Streptococci. Along with that, you will see the clinical features including the body temperature that would be increased, fatigue, chills, sweating, headache. Swelling is because of inflammatory edema. So the complication, it can be cavernous sinus thrombosis may occur, Ludwig angina may occur, or facial abscess may be seen. Treatment consists of antibiotic, anti-anaerobic. The treatment consists of antibiotic or removal of the cause of infection. Drainage could be done. Incision and the drainage could be done to facilitate drainage.